from Zimbabwe, who is a microbiologist and also the secretary and the Infection Control Africa Network Board. And she has a vast experience on infection control, including rolling out infection control programs in low and middle income settings. Welcome, Prof. Robertson. And at this time, I would like to welcome Prof. Shade Okushula, who is the president or the chairperson of the Infection Control Africa Network, to give us the welcome remarks. Thank you, and over.
Thank you much. Hello, everyone, to our 5th series on COVID-19. I am the College of Lagos, chair of the Infection Control Africa Network. In this series, how to keep on sustain the lesson this into our routine of care in our facilities. With every epidemic, we as a continent go into this frenzy of training on IPC. We put structures in place, we train staff, we buy PPE, disinfectants, all in a bid to combat the infection threat. And as soon as the epidemic is over, we go back to the status quo. This has not helped us, as healthcare worker infections and or death often herald the onset of another all the consequent negative impact on healthcare delivery, because our institutions lack the safety climate that is necessary and which is based on integrating and institutionalizing IPC. We therefore decided that we would shift our focus to the leadership of healthcare facilities, because they are the only ones that can make this happen. They are the only ones that can help us in integrating and institutionalizing IPC. They are critical in ensuring that there's a culture change within all our institutions. We will therefore, in the next 6 weeks, be looking at the WHO multimodal strategies on how to build it, teach it, check it, and leave it, and discuss how we use this model of behavior change to change the culture within our healthcare facilities to one of safety. I hope as we go through all this, we will all be very engaged and that we will have interactive sessions as we learn about the concepts and learn the best practices from each other. So on that note, I would ask you to please stay engaged, be very interactive, put together your questions, and we welcome you to another round of IPC for COVID in Africa. Welcome. Enjoy. Over.
Thank you, Professor Shade, for those welcome remarks. Now we're going to get to the main business of the day. We'll invite Ebeth to come and give us an introduction to administrative controls, and to find out, just briefly tell us how we can get to implement that as hospital managers and also as infection control practitioners. Thank you, and over to you, Ebeth.
Good morning, everyone. Thank you so much, Professor Sade and Lizzie, and then Professor Mohammed, for such a wonderful introduction to this series. I just wanted to put my camera on for a few minutes just so that you could put a name with a face. And then I'm going to go ahead and start showing my slides, if that's all right, and turn my camera off. But welcome to this 5th series related to infection prevention and control. I'm very excited to be able to have a session what administrative precautions are. I'm going to walk you through them today. I'm going to go ahead and turn my video off and share my screen. I I just want to make sure everyone can see my slide deck. Can everyone see my slides okay?
Yes, we can.
Okay. So again, welcome this morning. The title of this session is Infection Prevention and Control. Write your questions in the chat box, and I and Lizzie will do our very best to make sure that we've answered those questions for you. All right. So today, just to give you a quick outline of what we're going to talk about, first, we're going to have a bit of an icebreaker in terms of infection prevention and control. And then we're going to have an introduction into the current COVID-19 epidemiological situation that we are experiencing within our region. A very brief introduction to infection prevention and control and why it is important for us to ensure that we are correctly implementing these practices in our healthcare facilities. A description of what administrative precautions are and how they are very beneficial in terms of making sure that, especially during an epidemic and pandemic like COVID-19 we're experiencing, are very important in terms of facilitating behavior change. A short introduction to the chain of transmission, a brief explanation of behavior change and why it's important to make sure that when you're implementing IPC interventions, keeping behavior change and the desired behavior outcomes you want to see at the forefront of the planning process. An introduction to a myriad of strategies that can be used to successfully implement IPC practices. And then at the end, we're going to have a delicious panel discussion by our experts in the field. And then last but not least, we have an optional opportunity for all of you who have joined us today to engage yourself in an IPC implementation intervention throughout the duration of this webinar series. The training objectives. What I like to say about objectives is training objectives, webinar objectives, these are the guarantees of the session. So throughout this session, I, as sort of the facilitator, I guarantee that by the end of this session, you will have a better understanding of infection prevention and control concepts, specifically toward healthcare facility leadership, managers, and decision makers. You will be able to foster active learning through participatory-based activities throughout this session today on those IPC concepts. And the ones we're going to focus on today are administrative precautions. I'm also going to make sure that you are introduced to behavior change concepts and strategies to be able to support behavior change at your healthcare facility. And then, of course, to provide you at the very end a practical opportunity where you can implement some of the content that we talked about today after the webinar throughout the duration of our series through our assistance if needed. Are there any questions before I go forward? I want to make sure that we're all on the same page. And I also am trying to open up my chat box here, the Q&A session, so that way I can see if you have any questions for me. Okay, excellent. Well, let's get started. So the first thing I would like to do is an IPC icebreaker. For those of you who may be familiar with me, I really like to have an engaging session. So if you have questions at any point, please write them in the chat box and I will do my best to try to answer them in real time as best as I can. But before I begin, I love to talk, as you probably have gathered at this point, but I love it when you talk. So I would love for this first question, when I say infection prevention and control, what is the very first thing that comes to your mind? And can you please type your answers in our chat box? The very first thing you think about. Were you able to hear my question okay? Okay, yes, here we go. Hand hygiene, immunization, protocols, communicable disease, PPE, hand washing. I think of hand washing, social distancing. Okay, excellent. All of you are correct. I see a lot of focus on what we call the standard precautions, right? The basics of IPC. I see a lot of emphasis on transmission-based precautions. So looking at those activities that we would implement to try to prevent the actual transmission of a potentially harmful pathogen. And I believe I saw an administrative precaution amongst the group as well, which we'll talk about a little bit. For the most part, I see standard precautions. So perfect. Very good. Okay, second question. All right, everyone ready? When I say administrative infection prevention and control precautions, what's the first thing that comes to your mind? Measurement, triage, guidelines, hard to implement. Ah, that's a wonderful, wonderful response. Audits. I see lots of audits. I see a lot of IPC committee. Policies and guidelines and training. Okay, so this group is super smart and knows their stuff. So I am not going to have to worry too terribly much about taking too much into a deep dive here, but I am going to just talk a little bit and clarify a few concepts. So you guys are a bright bunch, and so we're just going to talk a little bit more about some very specific administrative precautions that frequently are overlooked when implementing IPC guidelines, protocols, or strategies. So thank you very much for everyone who responded, and I will continue to ask questions throughout the session. So I'm going to hand it over very quickly to my colleague, Susan, who's going to discuss a little bit more about the epidemiological situation specific to COVID-19, just so that as we are reviewing the content today in our webinar session, we can be reminded of where we currently are in our region in terms of COVID-19. Susan, I'll hand it over to you.
Okay, may I please share my screen?
Susan, are you able to hear me?
Yes.
Okay,
yes,
perfect. Thank you so much. I thought, oh no, I lost her. Thank you.
No, okay. I hope you can see my screen.
Yes, we can.
Yes. Okay, good afternoon, everyone, and welcome to the 5th series of Africa CDC webinar. I'm Susan Casey. I will present the epidemiological situation as of 9 a.m. today, 20th January 2020. Globally, there are over 94.1 million confirmed cases and over 2 million related deaths, with case fatality ratio of 2.2%. The map to the left shows the distribution of cases globally by country. The darker colors indicate countries that have reported more than 100,000 cases. The panel to the right is the epidemic curve showing the trend of COVID-19 cases reported daily by this organization regions. Africa is in the dark red color, currently accounting for about 3.5% of all COVID-19 cases reported globally. This slide shows the trend of COVID-19 cases in Africa from February 2020 to date. It shows the number of cases reported by day, and the red line shows the 7-day moving average. There are over 3.3 million cases reported and 80,000 reported deaths, with case fatality ratio of 2.4%. This map shows the distribution of cases in Africa. The darker red colors represent countries with over 50,000 cases. One thing to note for this week is Rwanda and Malawi moved to above 10,000 cases group. This table is showing the distribution of COVID-19 new cases, deaths, and recoveries. In the past week, 207, 803 new cases, 6,103 deaths, and 208 recoveries were reported from 55 African Union member state countries. 67% of the new cases and 76% of the deaths were reported from the southern region. South Africa alone accounts for 53% of all new cases. This map shows the distribution of COVID-19 cases reported in the last 7 days per 1 million population across the 55 member states. 38 countries reported less than or equal to 40 new cases per 1 million population per day. 4 countries reported between 41 and 80 new cases per 1 million population per day. 1 country reported between 81 and 100 new cases per 1 million population per day. 7 countries, that is Tunisia, Eswatini, South Africa, Seychelles, Cabo Verde, Namibia, are reporting more than 100 cases per 1 million population per day. The map shows the COVID-19 fatality rate by AU member states. 3 countries represented in darker red shows a case fatality ratio of more than 5%, and 17 countries in red are countries with a case fatality ratio of 2.4 to 5%. 1 country is reporting 2 to 2.3%, while 33 countries represented in green show case fatality ratio of less or equal to 2%. This graph shows the testing of COVID-19 cases across AU member states. Over 29.4 million tests have been done, with 8.9 tests per reported case, with 10% positivity. In the past week, number of tests have increased by 4%. Thank you.
Thank you so much for, go ahead, Lizzie, sorry.
I was saying thank you, Susan, for the updates, and we hand over back to you, Edith.
Thank you, Lizzie. Thank you, Susan. I'm sorry I jumped the gun there. That's how excited I get about talking about IPC, everyone. All right, let me share my screen again. All right, I'm hoping everyone can see this just now. Can everyone see the screen okay?
Yes.
Yes.
Okay, thank you.
Yes.
All right, so onwards and upwards we go. So very quickly, so a lot of you said the first thing that comes to mind when you think about IPC is hand washing, PPE, things of this nature. Just to give you a little bit more specific definition, infection prevention and control is really a set of scientific approaches with very practical solutions that have been evaluated and are evidence-based approaches that are used to prevent harm and cause infections within patients and healthcare workers. The scientific approaches are very much grounded, as I had mentioned, in evidence, meaning that they have been validated through sort of rigorous processes showing that they are effective in terms of in preventing infections amongst individuals. Infection control is also very much grounded in a background related to infectious disease, epidemiology, and healthcare system strengthening, with the critical focus point on being healthcare service quality to ensure patient safety and sufficient care. IPC is a basic requirement for outbreak preparedness and is a really critical element, an essential part of readiness. So infection prevention and control is not just a set of approaches or activities that we should use during an emergency like we're finding ourselves in right now with our pandemic. They're really ongoing activities that really should be undertaken and supported through a structured program led by an IPC focal person, team, or committee, whereby senior management and officials at a facility level and at different levels of healthcare systems are also managing and actively involved. IPC really is a continuum of activities where many individuals at a healthcare facility have to be involved. A group of individuals that are very critical at being involved in IPC at a healthcare facility are the health facility management, decision makers, and administrative individuals who are in charge of making decisions at the facility. So why is it, I won't spend a lot of time on this particular concept. I think most of us are generally familiar, but first and foremost, to reduce the transmission of diseases that can occur within healthcare facilities and communities. We want to ensure that our health workers, our patients, our communities, and our patients' social networks are protected and are prevented from harm. We also want to ensure that we are enhancing and facilitating an organization or healthcare facility's ability to respond to those emergencies when they do occur. Now, more specifically, what are administrative precautions? So many of you said you felt like you thought of protocols as some administrative precautions that you are aware of. Well, the truth is you are absolutely correct. The examples that you provided are indeed examples of administrative precautions. I'm going to talk a little bit today about other precautions that you may not be as familiar with, particularly to be used during acute crises like a pandemic. But more importantly, I'm going to show you different strategies that you can use as a healthcare facility manager or decision maker to really help influence behavior change amongst your health staff and other individuals involved in IPC at your facility. So very quickly, administrative precautions are a special group of IPC precautions that incorporate a lot of the examples that you provided me at the beginning of the webinar. But they're specialized precautions in IPC because they want to try to change the behavior of individuals in the event of a threat, like an emergency situation, or to prevent healthcare acquired infections. A more specialized version of administrative precautions are environmental controls. These are practices that we use to adapt the physical environment or workspace to make it easy to happen. Ooh, exciting stuff, right? I know I get excited. Administrative precautions are my favorite. So, what are some of the administrative precautions that we would want to use during this critical time during COVID-19? Well, as some of you mentioned, we would want to make sure that we have healthcare facility policies on how to essentially manage patients. So we also want to make sure that we have sufficient training for our health workers and associated staff involved in IPC practices at the facility. Some of you mentioned standard operating procedures or guidances that are very important at the healthcare facility level. And then screening and triage mechanism that as people enter into the healthcare facility for care, we are able to sufficiently rule out if they are a potential COVID-19 suspect. As I had mentioned, a triage station at every point of entry is very important during an acute crisis like an epidemic or pandemic. We want to make sure that we have very well laid out algorithms and pathways at healthcare facilities. So what does that mean? You might say, Beth, I don't understand what you're talking about. At each triage or screening station, you want to make sure that you have very clear pathways at the healthcare facility for how patients are going to physically move throughout the healthcare facility based on if they are deemed a suspect or not. Meaning, suspects will go through the healthcare facility in one pathway, non-suspects will enter and go through a different pathway. For those individuals who are identified as suspects or confirmed cases, you want to make sure that you have space somewhere within your healthcare facility to safely isolate those individuals until a confirmatory diagnostic test has been confirmed, or they have already been confirmed and should be separated away. You want to make sure that you have environmental controls built in. So one of the very important environmental controls is setting up a hand hygiene station throughout a healthcare facility at points where health workers can easily access them during patient care activities. Also, administrative measures for health workers who they themselves might have suggestive symptoms for COVID-19 and mechanisms in place so that they can be tested as well. A very important administrative precaution is making sure that also there are protocols and guidances in place related to what would health workers need to do in the event that they started to feel unwell. And then last, you want to make sure that you have established and strengthened staffed wellness clinics. So these would be spaces whereby health workers who are feeling unwell can safely and confidentially, as best as possible, of course, to be able to have an environment that is open and receptive to putting the health worker's mind at ease and feeling comfortable and letting occupational health know they are not feeling well. And the event that you want, that you have health workers that start to develop the COVID-19 symptoms, you want to encourage them to keep their distance and to stay at home, self-monitor until obviously declared negative. In the event that your health facility can do so, you would want to try to provide free testing mechanisms for your health workers, safe environments in terms of health institutions, safe PPE, and making sure that resources in general are adequate to take care of COVID-19 patients. You want to try to also explore incentives or motivational items that can be used in a way as token economy items in order to motivate health worker change. And of course, managers' support and appreciation, including mobilization within businesses and communities to also support health workers. All right, so I'm just going to briefly touch on what the chain of transmission is, and I'm going to just highlight some of the very important links that the administrative precautions can focus on. So for an infection to spread, all of the links on this diagram that you're seeing have to be in place in order to sufficiently perpetuate the spread of the infection. At any point, if you break any one of the links, then the disease can no longer be transmitted. So for example, with the administrative precautions, we had talked about there are a few administrative precautions. This is not an exhaustive list, but there are a few administrative precautions that are very important in helping to break the chain of transmission. Screening and triage mechanisms, isolation and quarantine mechanisms, and maintaining physical distancing of at least 1 to 2 meters are just a few examples of administrative precautions that can be used to break the chain of transmission. Can someone please type in the chat box, what part of the chain of transmission would get broken based on these 3 administrative precaution examples that I have shown you? Just type your answer in the chat box. What part of the chain gets broken with these administrative controls that I've just listed for you? Port of entry, mode of transmission, all parts of the chain. Okay, excellent. Mode of transmission. You're absolutely right. These specific examples are really geared toward breaking the mode of transmission, preventing the actual pathogen from further spread. This is a very bright group. I like it. I like it a lot. All right. So let's take a deeper dive. So we've talked about today about infection control and what administrative precautions are and how important administrative precautions are and why we use them. We use administrative precautions because we want to alter behavior, make sure that we are breaking the chain of transmission. We want to have our patients, our health workers, our communities change and modify their behavior so that way we can break that mode of transmission. So what exactly is behavior change? You might say, Ebeth, we're all doing behavior change now. It's COVID. Yes. However, let me just emphasize one key point. A lot of us who work in healthcare, there are many things that we know are good and evidence-based. For example, I know that screening patients at a triage center into my healthcare facility is a good practice to do to break the mode of transmission of COVID-19 entering into my healthcare facility. However, as a health worker working at the triage bay, screening patients, I screen patients very quickly with my questionnaire. I don't always answer all of the questions on my screening form because the screening form is long, and I don't typically take a temperature on the frontal or temporal lobe of patients coming in. I take their temperature side of their hand. Now, it's very important administrative precaution to break the mode of transmission into my healthcare facility, but I don't always do screening practices correctly. Behavior change principles really try to bridge the connection between an individual's attitudes, knowledge, and beliefs, behavior. An individual's decision to engage in a behavior depends on what that individual anticipates will actually be the outcome of the behavior. So many health workers know about different IPC practices, but they don't always implement them the correct way. I've already given you an example of an administrative precaution that is often not implemented correctly, but I want to take a deeper dive into an IPC practice that has been very well studied, that I would challenge you to walk into any health facility in our region and ask people that work in that facility, is hand hygiene important? Most everyone is going to say, absolutely, it is important. However, I would ask how many people working in the facility are actually doing the 10-step processing. So behavior change really requires us to bridge what we call the no-do. IPC practices are very important to break the mode of transmission, but we don't always do them correctly. All right. Is everyone with me so far? Everyone's feeling excited? All right, let's do it. So the WHO has a set of core components for infection prevention and control. There are 5 central components that one would have to think about if wanting to actually implement an IPC intervention. The first is what we called build it. And this is essentially those environmental controls or systemic changes that we would want to ensure that we've implemented before we start to actually change our practice. So you would want to make sure that infrastructures and equipment and supplies, those environmental things, we would want to make sure that the physical environment is in a way that we would want it to be to make our behavior change that much easier to actually implement. The second thing is teach it. We would want to make sure that we are correctly educating, training, and communicating with all of the individuals in the healthcare facility that are going to be involved in implementing the IPC intervention about the changes in the physical environment, about the importance of administrative precautions. So that way, when we implement our IPC intervention, we are not doing so in a vacuum or in a silo. After we have informed and communicated what our strategy is, we also want to make sure that we have ways to monitor and alter our process as we start to implement the actual intervention. So you want to be able to rapidly identify those gaps that can potentially impede successful implementation. We also then want to make sure that we are putting up visual and oral reminders and communicative information to constantly act as reminders for all of us involved at the healthcare facility level of the actual intervention. And this can be achieved by putting up posters, signs, having the matron or the chief medical officer during rounds give oral reminders, lots of different ways to keep the actual intervention at the forefront of people's minds. And then last but not least, we want to make sure that we live it. We want to make sure that we sustain our IPC intervention and that it becomes a part of our healthcare facility culture, just like many other practices become a part of our cultures at a healthcare facility level. The best example of this that I can provide you that has been very well studied and documented is actually hand hygiene. These 5 IPC components have been specifically used for this hand hygiene improvement strategy. Number 1 and number 2, as you can see, are the system changes. So what we have done is we've altered the environment where we put alcohol-based hand rub at each point of care, and we've ensured that continuous water supply, soap, and towels are available at various healthcare facilities to make sure that our environment is designed in the way that we want to. We've also made sure that we've trained healthcare facility leadership about hand hygiene, why it's important, what are the outcomes if it's practiced correctly. And then also we've had evaluation, monitoring and evaluation mechanisms routinely on hospital wards, in the cafeteria, in the nurses' waiting room or the health workers' waiting spaces to make sure that IPC interventions are maintained. Posters and visual aids have been placed throughout a healthcare facility to remind individuals of the importance of IPC. And then once many different strategies are used, we then were able to eventually have this become a successful part of the actual healthcare facility culture. The important emphasis I want to make here is that you cannot use only one strategy. You have to use multiple strategies to implement behavior change. And I'm going to talk about a few more strategies that we can use on the next slide. So we've mentioned a few strategies that can be used, all right, for sort of IPC core components. Here are a few other strategies. Some of these overlap with the WHO IPC core components, and then some of them may be a little bit different and novel. The first one we've talked about is education, training, things of that nature. We've talked about restructure policies and that we need to alter our physical environment in order to make the easy thing to do the right thing to do. We've also talked about quality management, monitoring and evaluation. Planning is something that we do before we implement our actual IPC intervention. So planning activities would also very closely align with restructure activities to ensure that the environment or a system at the healthcare facility level is sufficiently ready to go before actually entering into your intervention. Making sure that clear policies have been developed around IPC and the IPC intervention have been successfully communicated to everybody involved with IPC at the healthcare facility is really important. I cannot emphasize enough how important communication is when you're entering a new intervention into a healthcare facility. And last but not least, finance and incentives are very important strategy that may be used when wanting to change behavior around IPC interventions. And I'm going to talk a little bit more about different types of incentives and motivators that can be used, okay? But before I do that, I want to bring all of this together now in an implementation example using hand hygiene. So here we have the 5 moments of hand hygiene that have been outlined by WHO, and this is our evidence-based practice. We know that when we correctly implement hand hygiene, we drastically reduce the amount of pathogen on our hands, in the environment, on patients' belongings, and therefore are set up to break the mode of transmission. We have to successfully implement these evidence-based practices, though, using many different strategies. Can anyone tell me in the chat box, what is the #1 strategy that we use to promote behavior change? I'm going to give you a big virtual hug, a really big hug, an EBEF hug for whoever gets it right. Oh, I'm giving out lots of hugs today. Well, I'm going to have to give them to you at 1 to 2 meters apart because I can't obviously engage in physical contact, but I'm going to give all of you a big virtual hug right now. You are absolutely right. Training and education is the one strategy, it's the #1 strategy that we use to try to promote behavior change. I want to tell you something that is very important for all of you to know. You cannot change behavior with just training. I want to say it again. Behavior will not change if all you do is use training. This has been well documented in the academic literature. You must use multiple different strategies if you want to elicit behavior change. You can choose the strategies you want to use based on the context of your healthcare facility, but to only use one strategy and one strategy alone, especially training, will not yield behavior change. So let me show you what my colleagues and other colleagues around the world have done in terms of sufficiently implementing hand hygiene at the healthcare facility level to improve behavior change. Here are the implementation strategies. So #1, system change involves planning and restructuring, modifying the actual environment and having a strategic plan on how you are going to implement your IPC intervention is really important. Same thing here, system change, plan and restructure. Training and education. Education must be one of your strategies. Let me emphasize this again. Education alone will not yield behavior change, but education must be one of the strategies you use to promote behavior change. Evaluation and feedback is what we call quality monitoring. We want to make sure that we know that when we are implementing our intervention, how are we doing? We also want to make sure that this is also considered education. Education, reminders in the workplace are a form of mental model that helps to remind people at the facility of the right behavior to engage in. Now, we also want to have all of this lead to culture change at our healthcare facility, where we then have very firm policies on what the culture of IPC is at our healthcare facility. When you implement different strategies to promote behavior change for an IPC practice, these are some of the potential outcomes you can have. Increased efficiency, increased compliance with the actual IPC practice, penetration, having more and more individuals practice the IPC behavior, and therefore it becomes an adopted part of the actual healthcare facility culture. Okay? Now, before I talk about the actual opportunity that you have, I wanted to just let you know, I'm going to round up, but wanted to let you know that these are some of the strategies you can use. I'm happy to answer any questions at the end about different strategies you can use, particularly incentives or policy strategies, because not all incentives or motivators have to be financial. And so I just wanted to say thank you. I'm happy to be here with you today, and I will talk to you a little bit more in a few minutes about the actual IPC implementation project that is optional, that you are welcome to participate in if you would like to throughout the duration of this series. And I can talk a little bit more about that in a few minutes. Or Lizzie, did you want me to review that now?
I think we can get to review it on when we're doing the Q&A on the discussion session, if you don't mind.
Okay, perfect. So I'll stop sharing my slides and over to you. Thank you.
Thank you, Ebeth, for that very informative session. And I think for the healthcare managers and the IPC practitioners that have joined in today, we can at least have an idea of how we can implement those administrative and multimodal strategies in our day-to-day practice. And I hope it has been very beneficial to everyone who is listening in. And right now, I would like to kindly invite Evelyn, who is going to give us a talk about how they have implemented these strategies in Kenya. Over to you, Dr. Evelyn. Thank you.
Good afternoon and good morning to all of you. It's a pleasure to be on this webinar this afternoon or morning just to talk about the practical aspects in infection prevention and control. Ebeth, thank you very much for setting that well. And I just want to build up on what you have presented and what you've talked about with some practical experiences from Kenya. So I'll stop my video so that I can be able to go on with this presentation. Just look at presented on the administrative controls. I'll give a brief background of where we are at in Kenya in terms of implementing infection prevention and control, and also just look at the importance of monitoring the interventions that we are putting in place. And I'd like to focus on the primary health centers, because I know that most of our countries, when we started responding to the COVID pandemic, our focus probably was on the bigger or the higher level hospitals, and the primary healthcare facilities probably didn't get as much attention. And yet with the widespread community transmission, you realize this is a critical area in the healthcare system or the service delivery system that needs to be addressed. And also look at some of the aspects that influence our ability to change our behaviors, or also ability to have the right interventions in place at the right time so that we can be able to prevent further transmission of the infection. And through the experience that we'll have, what are some of the solutions that are probably made at a local level to be able to close the gaps? And I'll do this in the context of being in a resource limited setting. So this is just, we've recorded around 99,227 cases of COVID. And of course, our response to the COVID pandemic has not just been from the perspective of the Ministry of Health. It's been in collaboration with a lot of our partners. And for us, being in a country that has that embraces a system of devolution, our county health teams have been critical in this. And Ibeth talked about sustainable actions. Ibeth talked about going beyond the education or the training aspects. She also mentioned the importance of embedding all the interventions into routine practice. And this cannot be achieved possibly just by training or by having a policy. It needs collaborative effort at all levels of care. A lot of capacity building efforts have been put in place just to try and reduce the transmission of the infection. And you're going to see some examples that I'm going to share. The gaps that have been experienced, I believe in many of our countries, we have limited human resources at all levels. Monitoring and evaluation of the standards that are being implemented for infection prevention and control. I don't know how well each of our countries is doing, and also trying to monitor or evaluate the practices that are in place. I think, and also just to emphasize the primary healthcare facilities where you probably have one or two healthcare workers that are running this particular healthcare facility, and are torn between a lot of activities and duties and responsibilities that they have at this level of care. So our intervention was a project that is being run in collaboration with the Infection Prevention Kenya, ICANN, and Resolve to try and bridge the gaps that we're able to observe in the primary healthcare facilities. So what we did was emphasize that when you have a project running, it does have a lifetime. So the process of ensuring sustainability from the important. So we carried out an assessment earlier on that was led by the Ministry of Health. And this assessment looked at several areas of infection prevention and control, because we realized all these were important if we are to limit transmission. All of them communication and reporting. We looked at the importance of the presence and availability and accessibility of guidelines, and you can see all these other elements that we all are concerned with, like training, like triage, like preparing for a surge, or monitoring healthcare workers for exposure and eventual infection if that occurs. So we tried to assess all these specific elements to be able to know where our interventions would have priorities pegged on. So this is one of the counties that we have been responsible for. And I'll just follow through this specific country to just show or try and demonstrate how the assessments actually led to an increase in terms of support from leadership and management. And you can see the scores. Our target was to have an 80% across all the domains that we assessed. And you can see not so many of these areas that we assessed, it was able to score 80 and above. Some critical aspects like coordination and monitoring of healthcare workers, if you can see, scored like 23%, which is a big gap. And in terms of putting in place policies and maybe restructuring the way workflows in a health facility is really, really important. So overall, apart from just looking at the broader a county or a district that we actually went into, we went further and looked at the smaller, what we'd call sub-districts or sub-counties. how was each of these sub-counties performing, so that in the event that you have to put in place follow-up mechanisms, you're able to target your interventions, you're able to target leadership, you're able to target recommendations that you have made, you're also able to target resource mobilization based on the differences across the different countries. So we picked on the county that performed poorly overall and tried to follow through all the other elements that we were monitoring for. And you could see like the boxes that have a red a rectangle around them were for that specific county that consistently performed not so well in most of the assessment areas. And we went through all the different areas, and you can see in terms of guidelines, if you don't have guidelines available, and yet these have been developed as an administrative control. And if they're not available, then it means even the practice or the implementation of interventions are likely to have a challenge. And you can see the disparity between guidelines and availability of hand hygiene supplies in the same area. You have the supplies available, but the guidelines are not available. So probably the practice might be compromised at some point. Looking at aspects like training, I had Ebeth really talk about the importance of training and education. So without training, then probably also the availability of guidelines will not make much sense. But when people are trained and sensitized, they get to know that actually guidelines are available, and they begin to implement what the guidelines propose. So this was a same facility. I will not go through all of them. I just want to point out the monitoring of healthcare workers and inpatients for any possible COVID infection or exposure. You can see again, in terms of monitoring across all these sub-counties, that particular aspect of assessment or monitoring was very poorly done. And I think it's one other area we've been trying to emphasize, that as much as we are trying to take care of the general population, as healthcare workers, it is important for us to also know that we need to take care of ourselves. If the leadership and management is not sensitized to this, then we will not have a structure in place that will actually support the continuous monitoring of healthcare workers. So this same county again had like the second highest number of exposures to healthcare workers in the country. So it actually warranted some level of follow-up. So we went into one of the healthcare facilities in the sub-county that performed, that consistently had poor performance. And we looked at specific areas in the course of our visit. We have a tool that we have adapted, developed with the support of ICANN, that we use to follow up and track progress in terms of implementation. And it's important to note that every visit actually makes a difference. Even if you don't see the changes within the first 1 or 2 visits, but the presence of somebody just constantly checking on the implementation has been noted to be really important in terms of improving the implementation of the interventions. And you can see by the 4th visit, a lot of the reds are now turning into green areas, which means this particular aspect of monitoring, or the particular indicator, is actually being achieved as planned. And this is the same for many other indicators that are being tracked. We also keep evidence so that we are able to motivate the staff that are working in that healthcare facility that they are actually making progress. And you can see a big difference in the triage area between the 2nd visit and the 4th visit, where we didn't have clear signage just to be able to direct people on what this is. But by the 2nd visit, we had a triage area that was functional with clear signage, and the staff that are manning the area are appropriately dressed and also trained to be able to carry out their duties. Hand hygiene facilities, we had gaps at the beginning because, again, lack of knowledge, and Ebeth put it so well, the gap between knowing and doing. Healthcare workers know, but in terms of doing it, I think sometimes you have a challenge there, and that's the place of monitoring and evaluation. So we were able to see a difference, and you can clearly see the same hand washing area in the 2nd visit and in the 4th visit, after spending time with the team and having sessions of on-job training and a lot of communication and IC materials, you're able to see a change by the 2nd visit. And you can see even for waste management, a clear difference before an intervention and after an intervention. It might not be perfect, but they are on their way to improvement. Same hand hygiene stations. We had limited hand hygiene stations, but by the time we went in for the 4th visit, you can see we had more hand hygiene stations within the healthcare facilities. Where there were no sinks, they improvised. And I think this was really commendable, and that the team that was there was actually doing a great job. Of course, the challenges that we experienced were like practice against available supplies. If hand hygiene supplies score a 90%, but the practice is below 15%, then we realized there was a knowledge, there's a gap between what they know and what they actually do. Basic things like we realized the priorities of management, not because they didn't want to do it, but they were not aware. So even as we talk about administrative controls and we talk about the roles of leaders and managers, sometimes it's not because they don't want to be supportive, because for all the policies, all the training to happen, the management must prioritize infection prevention and control. And when we realized that, we decided to close the gap, first by talking to the teams. And this included healthcare workers, and we've put their support staff because we realized right from the gate, the security guards all needed to be on the same page. So we closed the knowledge gap by having sensitization meetings within the healthcare facilities. And the good thing is when we went in to support this particular county, we didn't do it on our own, but we actually brought on board the county infection prevention and control team to actually support the monitoring and evaluation and use their routine support supervision tool to recommend changes that the healthcare facility needs to put in place. So this ensured that we had a sustainability plan. So even after the project rolls out or closes out, they're able to conduct evaluation and also just supporting capacity building. And we moved on from the facility and held a meeting with the county health management team that involves the Minister for Health at the county level and their whole top leadership to disseminate the findings, because that is so important. Many times we have a lot of data that's collected, even hand hygiene data at the healthcare facility level, but do we disseminate this information? And if we do, what is our target audience? And when you select a target audience, what's your goal? What do you intend to get out of that dissemination meeting? So once we had this discussion with the county health management and we shared all the data, right from the broad county assessment findings to the facility findings at the primary health, healthcare facilities, which for us are our health centers, the county leadership was able to reprioritize their budgets to focus and address some of the gaps that we have identified. So sometimes it's not like resources are not available, they just need to be reprioritized so that the funds, which we all know are very scarce, can be used in a different way. So one of the things I want to underscore today is the central role that data and dissemination plays in supporting the implementation of administrative controls. Because if you're going to restructure your workflow, if you need to have extra infrastructure to support your processes, if you need to hire more staff so that you prepare for surges, if you need to have extra supplies brought into the facilities, if you don't have data, one, there's very little that you can do. And we will keep talking about these challenges. And if you have data and you don't disseminate this data to the right people, again, it becomes a problem. So what happened after the dissemination of the data? The county is now in the process of developing their county work plan for infection prevention and control, which they will use not just for these few healthcare health centers that we are supporting, but a work plan that will support the broad county and other healthcare facilities so that they can have a focused monitoring and evaluation process. And again, the other bit we also that also came out of this was the establishment of IPC committees at the healthcare facilities, and of course a review of the facility budgetary allocation to support the gaps that have been identified. So when you go back to the facility and you find through their support supervision options, they've been able to take this work forward. I think that's what we intend to do. That at the end of the COVID response, all the gains that we have made in infection prevention and control should actually be able to move a step forward, but that can only happen if we begin to, in a sustained manner, so that it becomes routine work and it's part of the processes that are adopted at at all levels, at the national level, at the regional level, and at the healthcare facility level. So I think that's the end of my presentation, just to show us that there is power in data. And when this data is disseminated, the administrative controls, again, have another angle that they can gain like strength from, where you can leverage data to actually drive action and decisions at several levels in the healthcare system. So Lizzie, I think this is my last slide. I would like to end there and just hand over, and just to encourage us to share the data that we collect and analyze it in its simplest form, because some of our leaders and managers are actually not healthcare practitioners, so we don't expect them to know everything that we know and identify with all the challenges that we have if we don't break it down for them. Thank you very much.
Thank you, Evelyn. Very informative, and I think there is a lot of take-home lessons that we can learn from the Kenya experience. At this point in time, I would like to invite Dr. Wande to take over and moderate the question and answer section. Over to you, Dr. Wande. Thank you.
Thank you so much, Lizzie, and thanks, Evelyn and Ibet, for a really fantastic session. I see that our questions, but I know just throw questions at the expert. So I think I would start with Zimbabwe. Really talked a lot about what we need from healthcare administrators, and from your own experience, I'm wondering if you can share with colleagues on the call, how do we go about engaging different stakeholders in improvement of IPC practices, just from your own experience in Zimbabwe?
Thank you very much. My experience in Zimbabwe is that that's actually a very difficult task, but a very important task. The idea of engaging also need to utilize structures that are already in place. Like in our setup, as the pandemic
I think we have lost Dr. Dege there.
Yes, so while we wait for him to reconnect, Evelyn, that was a fantastic presentation. And we just want to hear from you that right now we're in the middle of a pandemic, and we know that IPC is really important. But beyond COVID-19, IPC is really important in healthcare facilities, looking around healthcare associated infections. So based on your experience in Kenya, what are some ways to develop a culture of IPC at the healthcare facility level?
Thank you, Wande, for that question. And maybe just to quickly share my thoughts off the top of my head about the future of IPC post-COVID. Like I said earlier, we have such an opportunity to now build our structures around IPC. Number two, we have such an opportunity because the cadres of healthcare workers that are now sensitized to infection prevention and control are more and broader compared to when we had a training conducted for infection and prevention and control before the COVID pandemic. I say this because I know there's been a lot of struggle, even trying to get all other cadres on board, like the medical doctors, the surgeons, the physiotherapists, the occupational therapists, and we know all these plus support staff are supposed to be part of our IPC practices. But having seen the importance of infection prevention and control and having everyone embrace this right now, I think it's an opportunity for countries to have policies in place just to make sure that whatever efforts that have been gotten or gained through the COVID-19 response are not lost. And apart from that, we also want to make sure that we have some legal aspects that will make sure we have legal aspects embedded that will make sure that our work is actually made mandatory, that infection prevention and control standards are not voluntary standards, but actually mandatory to ensure that we have patient safety, we have a reduction in healthcare associated infections. So I think taking it a step further beyond general policy, but having legal requirements either through accreditation processes or quality improvement frameworks in countries that will make it mandatory for healthcare facilities and healthcare workers is going to help us sustain the efforts that we have put in place. Thank you.
Thank you very much. Just to sort of bounce off that question that Evelyn has answered so very well. Professor Valerie, this is to you. I'm just wondering if you could share with us some strategies that you think are most important in helping promote IPC practices in healthcare facilities. Prof. Valerie?
Yes, I'm here. Can you hear me?
Yes.
Okay. I think you have to work at two levels. I think, as Evelyn described really well, the importance of involving the senior management, in their case at county level, but also at national level, to make sure that they're full of IPC programs. But really for implementation, it has to be done at facility level. And I wish Dr. Degi's internet connection was a bit better, because he's a prime example of how he runs a provincial hospital, how through setting up a team of people who've had basic training in IPC, you can implement a program. And he's also managed, I'm speaking on his behalf in a way, to pull together. We tend to operate systems in different silos, and people get very confused. We have an IPC program, and then we have a quality assurance program. So how do the two connect? And obviously IPC is of quality assurance. So he's managed to bring a group of people who may have been trained in different silos, but pull them together to work together to implement standard precautions, transmission-based precautions, and extend the training through to all cadres within the health facility. But also what's important, and what we have in Zimbabwe, also is found in Kenya, is we have an IPC coordinator in each province. So through COVID, we've been able to work with the IPC coordinators to try and strengthen the systems, because as Ebeth pointed out, training really is not in site. Support visits with people who are experienced in IPC are essential. As Evelyn was describing, people understand what it takes to implement an effective IPC program. I hope that's answered your question. Thank you.
Thank you very much. I see Dr. Dege is back. I don't know if your network is fine now. Dr. Dege?
My network is better now.
Okay, Prof. Val really did a good sort of succinct summary of the great work you're doing in Zimbabwe. But just to throw this last question at you, is to say that we know it's not always easy. So what are the challenges or difficulties that you have experienced trying to change IPC practices? I think it's important that we learn the best practices and we also understand what the challenges are so that we can be better prepared to address them. So if you can share a bit of some of the difficulties or challenges you've experienced.
Thank you very much. The difficulties that you tend to come across is the aspect of the different professionals and even some who may not be in the medical field as well, being able to rally around one important cause. The trainings are different. The perceptions are also different. As you go up the higher levels, your doctors, your specialists, them to be involved in IPC issues, the tendency is to consider it as probably a nursing thing. Even other fields like maybe your physiotherapists, your occupational therapists, who for many a time have not been actually considered as part of IPC issues, which has sort of changed with COVID coming in, and people now realize the important role they can also play. So those are some of the sort of challenges that are there. The other issue is also management itself. Considering IPC as an area where you can actually invest in terms of training, in terms of even the infrastructure changes that are required, management may not see it as a critical area to actually invest in. So you may actually discover that even at national level, budgeting processes may not actually consider IPC as critical. So right now, if you look at even initially when COVID-19 started, I think most people were thinking about treatment rather than the preventive aspect where IPC is critical. So you would find that budgets would have been focusing more on the treatment, on the medicines, and the other equipment that may be required for the management of COVID-19 cases. Whereas the critical thing would have been to say, we want to reduce the numbers as much as possible. That's where IPC becomes very crucial. So those are some of the areas that I think we have noticed as challenges that we may need to really continuously address, that management really gets to be aware that IPC investment is actually a very good investment. And also that all the professionals have a very critical role, even the non-professionals, your cleaners, your nurse aides, they have a very critical role to play in IPC and even the environment, because they are also important in terms of wash activities. So there is need to also look at integrating of all the different activities and also making sure that IPC is part of quality and safety of care as well. That I think would make it even much easier to sell to management, to areas that I have noticed being challenges, and also areas that we could work on and improve going forward. Thank you.
Thank you very much. Ibet, I know that you're going to do a wrap up. That's why I've just decided to save you some of the questions. And I know Prof is also, I believe, scheduled to do a wrap up. Please, to the panelists, also have a look at the Q&A box. If you can type some of your answers onto that box, it will be very helpful. Lizzie and Ibet, over to you. And hopefully next week we can have more time for questions and answers.
Thank you, Dr. Wande. I'll hand over to Ebeth to wrap up her talk with the project.
Thank you so much. I will share my screen again so we can see the slides here. Here we go. So I wanted to share with those of you that are on today an opportunity which is completely optional, but we wanted to provide you an opportunity to practice some of the concepts that we're going to be talking about in this webinar series. And we came up with an idea of actually doing what we're calling a mini IPC implementation project. So this series is 6 weeks in duration, and throughout the duration of this series, we would like to give you an opportunity to identify an IPC challenge at your healthcare facility by engaging in discussions with health workers and health staff who are involved in making decisions or implementing IPC practices. This can be done with health workers on a ward, multiple ward, and a clinic, obviously with other administrators, laboratory techs, porter managers. But try to identify an IPC challenge at your healthcare facility by engaging some of the key stakeholders at the facility level about what are some of their challenges. And then review the different strategies that we've discussed today with individuals, including your health workers, about what strategies they would like to actually implement to address your identified IPC challenge. So get some feedback from those individuals who are involved in implementing IPC at your healthcare facility, and get some feedback on which strategies they feel like would be the most beneficial. Then you want to agree on the set of strategies and basically provide and design a brief implementation plan of how you're going to implement those strategies to improve whatever your challenge is. So again, you can look and reference the hand hygiene example I discussed today. You want to then make sure that you communicate very broadly about the implementation of the project, which is supposed to last 6 weeks, which is the duration of this webinar series. So you want to make sure that you pick a challenge and strategies that can be implemented within a 6-week period of time. Depending on your challenge that you've selected, you would also want to make sure that you can do a very quick baseline assessment of the challenge, and then of course, have some way of doing sort of a post-project assessment. You will want to make sure that you are sort of routinely evaluating the strategies that you've implemented throughout the duration of the project. And at the very end of the webinar series, at the last session, session 6, we would invite you to participate in giving us a brief presentation of what was your IPC challenge, what strategies you used to address your challenge, and overall, what were some of the successes and some of the additional challenges of implementing the strategies, and give us a little bit of feedback on that last day. One of the things that we would like to say is, again, this opportunity is optional, but if you are in presentations be judged by an external IPC expert, where we will have specific criteria that you will have to use that we will share with you. And those projects that are deemed the sort of the best based on the evaluation criteria will be recognized on one of the ICANN or Africa CDC websites or blog posts to be able to share your accomplishment with others. Was everyone able to hear me okay?
Yes.
Okay, wonderful. And as I said, if you are interested, please send us your information, and then we will work to make sure that you have the evaluation criteria that you can have so that you know what your project will be evaluated on. Over. Thank you so much.
Thank you, Ebeth. Thank you, everyone. Special thank you to the panelists and the hospital managers from across the globe that have managed to join in today. And I hope that today's webinars, the sessions were very enlightening, and we have some take-home lessons that we can get to use as we implement our various IPC programs in the various workplaces. So for today, this is the end of our session, and I am going to hand over to Prof. Shade to give the closing remarks. over and thank you.
So I just looked at the list and I think that Prof is off. We'd just like to say thank you on behalf of Africa CDC ICANN, WHO Afro, and Resolve to Save Lives, and all of our other partners that have worked together to put this new series, to get this new series going. We'd like to say thank you. And most importantly, to all the participants that have joined this session. We will not be able to do anything without you. So thank you very much, and thank you for your time. And look forward to speaking to you same time next week. Bye.
Bye, and thank you.
Bye-bye. Have a good day,
Bye.
everyone.
Bye. Thank you.
Thank you.